Greetings. Let us look at endoscopic findings in a patient who has gastroesophageal reflux disease, otherwise known as GERD. And here is a patient. This young lady has been having heartburn for several months and regurgitation of food after a big fatty meal. And a couple of times she also had chest pain. These are the symptoms of acid reflux or GERD. And when you undertake endoscopy in such a patient, you go through in a very systematic way. A majority of the patients with gastroesophageal reflux disease may have completely normal findings. And let us look at what normal findings include. So when the endoscope goes down, you examine the squamous lining or the esophageal lining, whether it is clean and intact, or whether there are any signs of damage. Damage with acid reflux is typically seen as breaks in the lining or otherwise called as erosions. So the first thing is you say whether there are erosions or no erosions. Next, you go down and look at the anatomy of the lower end of the esophagus, whether the esophagus goes through the diaphragm and then enters the stomach, or whether the stomach actually comes up into the chest, what we call hiatal hernia. So in a normal person without hiatal hernia, when you go down to the lower end of the esophagus, as the patient takes a breath in and a breath out, you will see the pinching effect of the diaphragm on the esophagus. And you see that pinching effect in the insert there as something that is pressing the esophagus in and out with each breath. And that's where you mark the position of the hiatus. In an adult male, the hiatus could be around 40 centimeters from the incisors. And then once you mark the hiatus, then you go down and look at the squamous-columnar junction or the Z line. The squamous-columnar junction, the squamous lining of the esophagus is pink, the columnar lining of the stomach is beefy red. And where the junction is, that is also called Z line, you will see that at the lower end of the esophagus like a clear line. And in the insert, as you can see, the squamous-columnar junction. And another mark that is important to keep in mind is the gastroesophageal junction. That is, the gastric folds, where the top of the gastric folds end, is where the gastroesophageal junction is. In a majority of the people, the squamous-columnar junction and the gastroesophageal junction are about in the same place. So you mark the gastroesophageal junction, and when you look through the scope, you'll see the top of the folds, and where they end, that's where you mark the gastroesophageal junction. What an endoscopist does to figure out the exact location of the gastroesophageal junction is he may try to suction some of the air or CO2 to decompress so that the folds become more prominent. So this is what a normal esophagus and a normal gastroesophageal junction looks like. So the normal esophagus is pink without erosions, and a normal esophagogastric junction is where the esophagus goes through the hiatus and then enters the stomach. The stomach is below the diaphragm. In patients who have hiatal hernia, part of the stomach actually comes up through the hiatus into the chest. In other words, the gastroesophageal junction moves up and the stomach actually prolapses up into the chest or slides up into the chest through the hiatus. That's why it is called sliding hiatal hernia. So what happens is when you do markings here, the first thing you notice is the squamous-columnar junction and the gastroesophageal junction. And say, for example, the endoscopist says squamous-columnar junction, gastroesophageal junction, location 37 centimeters at the incisors, and then he goes down and says hiatus is where the diaphragm is pinching on the stomach is at 40 centimeters. Then you know 40 minus 37, that is 3 centimeter hiatal hernia. So you can figure out that, right? So next, when you bring your scope down and you are looking for the diaphragmatic pinch, that's where you see with each breath, you will see a movement in and out of the stomach folds, and you know that's where the hiatus is. So, while we are looking at sliding hiatal hernia, it is also a good idea to cover what is paraesophageal hiatal hernia. In paraesophageal hiatal hernia, the gastroesophageal junction is pretty much located normally. The esophagus goes down through the hiatus into the stomach below the diaphragm, but part of the stomach, that is the fundus of the stomach, prolapses up through the diaphragm parallel to the esophagus. So these patients may not have acid reflux symptoms because their junction is otherwise normal, but they may present with pain, and sometimes they may develop an emergency if the paraesophageal hiatal hernia develops kinking or strangulation. So let us look at, we understood the normal anatomy, and let us look at the findings. And I am going to show you cartoons followed by real pictures. So here is a patient who has heartburn, and when you do the endoscopy, it pretty much looks normal. You can see there is clean esophagus, no erosions. The gastroesophageal junction, squamous-columnar junction looks normal. And this is called a normal esophagus. And when you take biopsies from this patient, where the esophagus looks completely normal, and on microscopy, the pathologist says there are changes suggestive of acid reflux, then it is known as non-erosive reflux disease. So basically, there is reflux, but the lining has not broken down, or in other words, did not create erosions. That is non-erosive reflux disease. And if the damage starts happening, milder damage, like a small break or an erosion of less than 5 millimeters without crossing across the folds, is labeled as grade A by the Los Angeles classification. If the erosion becomes longer, more than 5 millimeters, and doesn't go across the folds, it is grade B. If it crosses the folds but is less than 75% of the circumference, then it is grade C. And it is more than 75% of the circumference, then it is grade D. So depending upon the length, 5 millimeters or more, A or B, and then whether it is going across the folds, then C, and then more than 75% of the circumference is D. So it's important to keep in mind and use this classification whenever we report the staging of the erosive esophagitis. So let us now look at what the endoscopist looks at, real pictures. So as you can see here, there is an arrow there there is a very small erosion at the squamocolumnar junction. It is less than 5 millimeters. It is grade A esophagitis according to the Los Angeles classification. It's otherwise called LA grade A. Here, the erosion is a little bit longer, certainly more than 5 millimeters, and there's no crossing over to other folds. It is grade B. And then here, as you can see at the bottom, not only the erosions are longer, but they are going across the folds, but not 75% of the circumference. That is grade C. And finally, here it is pretty bad. It's going all over the circumference, certainly more than 75% of the circumference. It is grade D esophagitis. So in this presentation, we have learned about what a normal esophagus looks like, normal GE junction, hiatal hernia, and various grades of erosive esophagitis. Thank you.